Hello, and welcome to this lecture on shoulder disorders and rehabilitation. Today, we'll explore the common disorders and some rehabilitation strategies. Let's get started. The shoulder is unique because it offers an incredible range of motion, allowing us to perform activities like reaching overhead, throwing, and lifting. However, this mobility comes at the cost of stability. Unlike the hip joint, which has a deep socket, the shoulder's glenohumeral joint has a shallow socket, making it inherently unstable. This instability makes the shoulder prone to injuries and disorders, such as rotator cuff tears, impingement syndrome, and adhesive capsulitis, frozen shoulder. To maintain stability, the shoulder relies on a combination of osseous structures, ligaments, muscles, and bursae. For example, the glenohumeral joint is stabilized by the rotator cuff muscles, which compress the humeral head into the glenoid cavity. The acromioclavicular joint and sternoclavicular joint allow for coordinated movement of the scapula and clavicle during arm elevation. The subacromial bursa reduces friction during motion, but can become inflamed due to impingement, leading to pain and limited movement. Understanding the biomechanics of the shoulder is also crucial. For instance, during arm elevation, the scapulohumeral rhythm ensures that for every 2 degrees of glenohumeral motion, there is 1 degree of scapular motion. This coordinated movement is essential for full range of motion and stability. Finally, we will discuss a bit the physical examination. We will also cover common lesions such as rotator cuff tears, impingement syndrome, and frozen shoulder and their clinical implications. Let's begin with a quick review of the shoulder's functional anatomy. The shoulder is composed of 4 joints: the glenohumeral joint, acromioclavicular joint, sternoclavicular joint, and scapulothoracic mechanism. The rotator cuff muscles, known as sits muscles, including supraspinatus, infraspinatus, teres minor, and subscapularis, respectively, are critical for stabilizing the humeral head during movement. Without them, the shoulder would be prone to dislocation. Proper scapular movement or scapulohumeral rhythm ensures that the glenoid fossa is optimally positioned for arm elevation. Dysfunctions such as scapular dyskinesis can lead to shoulder pain and impingement. Finally, the subacromial bursa reduces friction between the rotator cuff tendons and the acromion. Inflammation of this bursa is a common cause of shoulder pain. Now, let's discuss the most common shoulder disorders: impingement syndrome, shoulder instability, adhesive capsulitis, and acute bursitis. Impingement syndrome occurs when the rotator cuff tendons or subacromial bursa are compressed beneath the acromion. Neer classified it into 3 stages. Stage 1, edema and inflammation. The clinical features of this stage are pain with overhead activities, painful arc, 60 degree, 120 degree abduction, night pain. Stage 2, fibrosis and tendinitis. The clinical features of this stage are persistent pain, thickening of tendons, reduced range of motion. Stage 3, rotator cuff tears. The clinical features of this stage are significant weakness, inability to lift arm, positive drop arm test. Following tests could be used for physical examination: Hawkins impingement reinforcement lest abnormal near impingement sign often present, supraspinatus resistance testing often painful arc of abduction often present, subacromial bursa tender. To treat the acute phase of impingement syndrome, focus on reducing pain and inflammation. Use rest, ice, NSAIDs, and gentle pendulum exercises. In the subacute phase, begin rotator cuff and scapular stabilization exercises. Gradually reintroduce functional activities in the advanced phase. Shoulder instability can result from static or dynamic factors. Dynamic factors, primarily caused by rotator cuff weakness. Static factors include damage to the anterior capsule, glenohumeral ligament, and glenoid labrum. Shoulder instability can be traumatic or atraumatic. Traumatic instability is unilateral, unidirectional instability and often involves a Bankart lesion and may require surgery. A Bankart lesion is an injury of the labrum and associated glenohumeral capsule. Physical examination. 1. The following signs could be presented in the case of anterior instability: apprehension in response to apprehension test, reduction of apprehension in response to relocation test, increased anterior laxity to passive testing like drawer test, load and shift test. 2. The following signs could be presented in the case of posterior instability: increased posterior laxity to passive testing like drawer test, load and shift test. 3. The following signs could be presented in the case of multidirectional instability: abnormal sulcus sign, increased anterior and or posterior laxity to passive testing like drawer test, load and shift test. Treatment: the traumatic instability often requires surgery for stabilization. Atraumatic instability is often multidirectional and responds well to rehabilitation. If conservative treatment fails, an inferior capsular shift procedure may be performed to tighten the capsule and rotator interval. Patients may report a feeling of the shoulder slipping out or apprehension during certain movements. For shoulder instability, focus on strengthening the rotator cuff and scapular stabilizers. Avoid provocative positions such as excessive external rotation in abduction. Spasms, adhesive capsulitis. Adhesive capsulitis, or frozen shoulder, is characterized by progressive stiffness and pain. It has 3 stages: freezing, frozen, and thawing. Patients have global loss of passive and active range of motion, especially in external rotation. It is more common in women and middle-aged to older individuals. The adhesive capsulitis is often idiopathic, but may be linked to scapulohumeral alignment changes like thoracic kyphosis, systemic conditions like diabetes or thyroid disorders, immobilization after injury like fractures, dislocations, reflex sympathetic dystrophy. For treatment of adhesive capsulitis, use gentle joint mobilizations, particularly inferior and posterior glides and stretching exercises like the crossbody stretch and sleeper stretch. Passive mobilization by a skilled therapist is crucial in the early stages to avoid muscle spasms and impingement. Start with grade 1 or 2 oscillations to reduce muscle spasm and pain. Progress to grade 4 techniques for more vigorous stretching. Inferior glide with the arm at the side is particularly effective for inducing relaxation. Use ultrasound to enhance tissue extensibility during capsular stretching. Combine joint mobilization with functional movements, e.g., inferior glide with abduction, posterior stretch with internal rotation. Instruct home range of motion exercises. Acute bursitis often results from overuse or impingement or calcific tendinitis, where calcium deposits migrate into the subacromial bursa. Patients present with severe pain, limited motion, and tenderness over the bursa. Now let's discuss the rehabilitation process for these disorders. The approach varies depending on the condition and its stage. For acute bursitis, rest, ice, and anti-inflammatory measures are key. Soft tissue mobilization, myofascial release techniques, and joint oscillations to reduce pain and muscle spasm. Correction of biomechanical deficits through joint mobilizations. Gradually reintroduce range of motion and strengthening exercises as pain subsides. It is necessary to understand that sometimes recovery is gradual, and both therapists and patients should be prepared for periods of limited progress. Glenohumeral subluxation and dislocation. Joint dislocation happens at closed packed position of a joint more than at its open packed position. The closed packed position is the position which results in maximal tautness of the major ligaments, maximal surface congruity, the least transarticular pressure, Any positions of the joints other than the closed packed position are known as open packed position of the joint. The closed packed position of the glenohumeral joint is abduction and external rotation. 95% of shoulder dislocations occur in the anterior-inferior direction. Anterior-inferior dislocation typically results from forceful external rotation of an abducted arm, leading to damages in the inferior glenohumeral ligament, anterior capsule, and sometimes the glenoid labrum. Posterior dislocations, which occur with horizontal adduction and internal rotation of the shoulder, are rare and often associated with multidirectional joint laxity. complications may include a Hill-Sachs lesion, which is known as compression fracture of the humeral head, SLAP lesion, which is known as tear of the glenoid labrum, Bankart lesion, which is known as avulsion of the anteroinferior capsule. Glenohumeral subluxation and dislocation. Post-surgical repair patients should avoid positions that cause apprehension, like positions including flexion more than 90 degrees, horizontal abduction more than 90 degrees, external rotation more than 80 degrees, correct joint restrictions with mobilization, myofascial release techniques, restore shoulder mechanics through strengthening, endurance, and coordination exercises, focusing on scapulothoracic and glenohumeral stabilization. Thoracic outlet syndrome is defined as the compression of the neurovascular bundle, including brachial plexus, subclavian artery and vein, vagus and phrenic nerves, sympathetic trunk in the thoracic outlet. The thoracic outlet is formed by the scalenus anticus and scalenus medius as the anterior and posterior walls of the thoracic outlet, and first rib as the bottom of the outlet. The thoracic outlet syndrome occurs when the thoracic outlet's size or shape is altered. Adson's maneuver, Allen's, Roos, Wright, and costoclavicular tests are the main physical tests for thoracic outlet syndrome assessment. Superior thoracic outlet, scalene triangle between the clavicle and first rib, and between the pectoralis minor and thoracic wall are the common compression sites. Acetaminophen for pain, NSAIDs for pain and inflammation are used. Treatment of thoracic outlet syndrome. Physiotherapy goals include address the underlying cause, focus on postural re-education, functional training, and correcting muscle imbalances. Use joint mobilizations and manipulations to reduce pain and soft tissue abnormal tension. Surgical treatment may include removing a cervical rib or releasing the scalene muscles.